Yes, good afternoon, everyone, and good morning to our colleagues who are in the US. Welcome to our first Pediatric Emergency Medicine Symposium for the year 2026. So we are very happy to have you join in again for this year, and this is going to be our first Pediatric Emergency Medicine series. And we're very happy today we're going to be having two of our presenters, that is Dr. Juma Mbugi, who is currently a pediatric emergency medicine fellow at MUHAS, and we're also going to be having Dr. Cassidy, who is a pediatric emergency medicine fellow from the University of Utah. We're going to be having a very interesting topic, and the topic that opens our 2026 PEM lecture series is General Approach to Pediatric Burn Patients in Emergency Setting. So I'm very happy to have you join in, and we know you'll be joining in on all the subsequent series that will be following up every month. And as we always will keep on sharing within the group to update you when is the next PEM lecture series and what topic is it going to be. And for this year, it will almost be the same, but the only difference is we'll share all the topics that we expect to present in all this year so that you can also prepare yourself and come up with questions that you might have. But as well as we go on with the presentation, you are allowed to put your questions in the chat as always. If you have any question, you want any clarification, just put it on the chat and the presenters will answer in the end of the presentation. Again, to remind you, this is also a CPD accredited activity where you have 3 CPD points from MCT. Just make sure write your name and your MCT registration number on the chat. And one last thing that I'd also like to welcome you all as we go on. In the chat, I'll also put a link that you can keep on suggesting what topics is it that you want us to prepare for you, which are going to be helpful as we go on with the Pediatric Emergency Medicine lecture series. So without wasting time, I would like to welcome Dr. Mbugi and Dr. Cassidy to go on with the presentation. You're all welcome.
Thank you, Dr. Humphrey. My name is Juma Mbugi. I'm a pediatric emergency medicine fellow from MUHAS University, from Muhimbili University of Health and Allied Sciences. I'll be with Dr. Cassidy. I think, Cassidy, you can introduce yourself.
Hello, everyone. Thank you so much for having me. My name is Dr. Cassidy Huun. I am a second-year pediatric emergency medicine fellow at the University of Utah. I'm also a global health fellow, so I spend quite a bit of my time in Tanzania as well. So I really appreciate everyone welcoming me to do this lecture with Dr. Mbugi today. All right.
Thank you.
First off, we don't have any financial disclosures for this lecture today. Just to review some objectives and what we hope to cover today in today's talk, quite a bit to discuss, but really the goal is to go over a general approach to pediatric burn patients that can be used in a variety of different settings, not just at a high-level hospital that has a burn center. So first, we'd like to discuss burn injury burden in Tanzania. Then we review the causes of burns that affect pediatric patients that we see. We'll describe the classification of burns and how to identify them. Then we'll go over some key differences in pediatric versus adults, review the assessment of pediatric patients with burns, review the initial management of these pediatric patients with burn injuries, describe burn injuries that may raise concerns for non-accidental injuries, and then discuss some of the potential complications from burns. All right, so as far as the burden of pediatric burn injury in Tanzania and sub-Saharan Africa, there's still limited data on the true numbers. There have been some studies that have looked into this. There was a survey study that was done in Dar es Salaam suggesting that burns represent almost 16.3% of all reported injuries among children, and that there was an incidence rate of almost 2% per month that were just burn injuries in the pediatric section. There's a pediatric injury registry at KCMC that suggests that burn injuries make up a significant proportion of the pediatric hospital admissions and carry the highest mortality risk for what kids can be admitted with. The highest risk age group for sub-Saharan Africa and Tanzania as well is the 0 to 5 years age group. The most common type of burn, which we'll go over in more detail in just a few minutes, is a scald burn from hot liquid, followed by flame injuries as the second most common. So when thinking about pediatric burns in this setting, it's important to note that there's higher mortality rates than in high-income countries. A lot of this has to do with resource availability and not having always easy to access high-level burn centers. In northern Tanzania, there was a study done that reported that about 43% of in-hospital deaths among children were in children who had burn injuries, and they had a greater than 8 times higher odds ratio of mortality compared to children with other injuries. A common theme that has also been described in some of the literature is that there's quite late presentation to healthcare facilities when a burn injury occurs. In one study, they found that almost 80+% of patients that had a burn injury sought care at a healthcare facility greater than 24 hours after the initial injury was happening. Risk factor for burn injuries in this setting, there's limited access for some families to electricity and safe cooking infrastructures. There's a lot of ground level cooking fires, and then not like safe stoves inside the house. Use of sometimes still kerosene stoves and lamps, and then just being able to monitor kids while we have things like ground level cooking fires, stoves that don't have proper safety mechanisms, things like that. All right, I'll hand it over to you.
Thank you. So let's review the types of burns that children are likely to get. One of the commonest types of burns is the scald burns. This is caused by hot liquids and steam. It's the most common type of burn in young children. And the severity actually of the scald burns depends on type of hot substance, its viscosity, and duration of exposure to the skin. And usually the scald burns occurs in domestic settings, like kitchens, as you can see. Dr. Cassidy, please, the previous slide. The scald burns usually occurs in domestic settings, like kitchens and bathrooms, dining. Can I see the last slide?
Sorry, it's not letting me go back, so I apologize.
Okay, no worries.
I don't think I'll be able to go
forward?
back.
We can just continue.
Okay.
So the other type of burns is contact burns. That a child coming into contact with or touching a hot surface like a hot iron or stove top. So most often this will involve the upper extremities, as it is illustrated in the picture, a child trying to touch a hot iron and can inflict such burn injuries on the right picture. Next. And the other type of burns is flame burns. This is caused by a direct contact with fire. And usually the burn injuries are deeper and wider, and usually typically associated with surgical interventions and longer hospital stays as well. And these are kind of burns that usually the patient gets full thickness burns and usually require a complex medical care. Next. Chemical burns is one of the types of burns that also children can get, mostly from alkali or acidic burns, which happen with exposure to the household products most of the time. Household products that are left in their reach. So usually we recommend to put those kind of things out of reach of children. So make sure those who are providing care in patients with alkali or acidic burns, they are wearing a proper PPE to avoid themselves to be the victims. And usually remove all the clothing of that patient, followed by initial dilution with water to make if there was chemicals still on the cloth. And the last is the electrical burns. So usually electrical current flows in tissues with low resistance, like heart, blood vessels, nerves, and muscles. So whenever electrical current meets something with higher resistance, even the damage will be higher. So when an electrical current flows through a substance with the resistance, the heat energy will be generated. And this is the thermal energy. This is what is causing the burn injury. So the low voltage, usually less than 120 volts, burns can lead to local contact burns. And the higher the voltage, the higher the burn injury as well. Usually high voltage, like more than 500 volts, will have an exit to the point that the patient is touching the source of electricity, and to the other point that is touching as an exit of the electricity. So Dr. Cassidy, I think you can carry on that.
Thank you so much. So now that we've reviewed the different types of burns, we want to move in to how we classify the burns. And you might have heard him kind of describing things like full thickness and partial thickness. So we'll kind of review that now. So this is the classification of burns. And you might have heard people in the past say things like first-degree burn, second-degree burn, third-degree burn. This is the newer terminology that we used to describe it. So we have superficial partial thickness, deep partial thickness, and full thickness. So here's a diagram kind of showing the superficial causing more of like a pink and reddish discoloration due to damage to the epidermis, partial thickness extending further down and causing things like blistering, and full thickness is going all the way down and causing further damage. So for a superficial burn, we're thinking the depth is the epidermis only. So on your exam, the area will be quite erythematous. It'll be painful, but it should be non-blistering. These are things that will usually heal within 4 to 5 days, and the scarring risk is quite minimal. The next step up would be a superficial partial thickness. So this is including the epidermis of the skin as well as the upper dermis. So you'll have blisters that are painful when you unroof them. There'll be like exposed pink skin that's moist and blanchable. So when you unroof the blister, it should be pink skin. It's blanchable when you test it, and there's also intact capillary fill. This one takes a little bit longer to heal, around 7 to 10 days. Still has that very minimal risk of scarring, but there might be some hypopigmentation as part of the recovery process. Moving on to deep partial thickness. So this is going to extend from the epidermis through the deeper dermis. On your exam, you'll have blisters that are easily unroofed or already unroofed on their own. There'll be erythematous or yellowish discoloration. They'll kind of have a waxy and dry appearance. These will be less blanchable, if they're even blanchable at all. Depending on how deep it is and the extent of nerve fiber involvement, they may or may not be quite painful. You might be able to see some of the hair follicles, and you can sometimes see capillary bursts. So you'll have like little red dots there where it's bleeding, if that finding is present. These take quite a bit longer than our first couple of burns we discussed, taking 2 to 3 weeks to really heal. And these have a much higher risk for scarring. Now we move into the full thickness burns, or what used to be called like a 3rd-degree burn. So this is involvement of the epidermis and the full dermis. So this will have a white, waxy, and they often describe it as a leathery appearance. There will be absence of the hair follicles, and you've extended far enough down that you've caused quite a bit of nerve damage. So a lot of times these will be insensate or painless. There can still be some nerves that are running through, so don't think it's fully painless. You don't have to provide any kind of pain management, but you might not have the patient respond to you testing for pain in those areas. These take weeks to heal depending on how extensive they are, and these will definitely cause scarring. They still have a category for 4th degree. This is when you have full thickness burns that extend into the deep structures, making them visible, things like muscle, bones, and tendons. They'll have like a very charred appearance with visibility of those deeper structures I just described. These take months to recover from, and you will also have scarring for sure. All right. I'll turn it back over to you.
Sure, thank you. So, the initial steps to take when assessing pediatric burn patients is almost the same as any other child or a child that has sustained any trauma. The steps are almost the same. You have to take the approach as any other child. But in burn patients, we have to consider special considerations in pediatrics, especially the body surface area in children is almost 3 times the body to body mass ratio is almost 3 times of that of the adults. And the possibility of having a non-accidental injuries in children is also something to consider when attending pediatric patients with burn injuries. And children have higher metabolic rate that increases oxygen demand and glucose demands as well. And deeper burns occur in children with burns because of they have thinner skin. And the thinner skin also causes increased permeability and loss of water as well. So different fluid resuscitation thresholds has to be considered as well. And children have smaller airways that increases also the risk of obstruction. So how do we go about it? So the assessment usually, as I said, it's almost the same as any other child with trauma. So you always have to observe your safety first, and if necessary, call for help so you cannot be alone, and then go ahead assessing airway and breathing, circulation, disability, and exposure. Let's see one by one. So airway, usually assess for obvious signs of the airway compromise, and consider smoke inhalation injuries based on whether they come from the house fire. And the other thing to look for is the soot in the mouth or burns to the face or the nasal hair, something like that can also tell you that my child is having something like inhalational burn injury. And in children, airway edema can progress so rapidly, and they usually have small diameter. So whenever there is an edema, the diameter goes much more smaller than expected, and can make airway impossible, and even intubation can be very impossible. So with this, usually consider early intubation in case of inhalation burn injury as soon as possible, as soon as you suspect inhalation burn injury. Do not delay to intubate. But remember, do not intubate prophylactically if there are no supporting features of airway burn. So this is the effect of airway edema in infants and children compared to that of an adult. So normal airway is approximately 4 millimeter, and whenever it becomes edematous, it's almost down by 50%. And the airway resistance becomes higher, 16 times more. Unlike the adults, whereby the airway is a little bit 2 times more, 8 millimeter, and when it becomes edematous, it becomes only maybe 6 millimeter, but it depends on the extent of or severity of the inhalation of an injury. And the change in diameter in adults can be as less as 25%, with airway resistance of about 3 times more than the normal airway. So what are the signs of inhalational burn injury? We have seen some, but always suspect inhalational burn injury in a patient coming from a fire, an enclosed fire, like a burn house, or any fire, maybe a warehouse was burning, or a house at home, it was burning by whatever the reasons, but suspect inhalational burn injury in an enclosed fire. And facial burns, usually the patients that we normally receive here with inhalational injury have facial burns, hoarseness of voice, stridor, and large burn areas that can cause edema. Can be edema, burn of the neck, chest as well, head. And whenever you observe soot in or around the airway, should raise concerns. Usually soot on the nostril or the burnt hair nostril, in the nostril or in the mouth. So usually raise concerns about the inhalation burn injury. And why is this important? Because with compromise of the airway or the presence of inhalation burn injury in patients with burn injuries can increase the mortality up to 50%. And usually, if no action is taken early, these kind of patients lose life maybe within 48 hours. So after airway, the other thing to assess is breathing. And in patients with circumferential chest injuries, burn injuries, or abdominal burn injuries, usually they limit the lung compliancy. The chest movement is limited, and usually take care of circumferential and chest injuries and abdominal injuries. And think about, especially in patients sustaining burn injuries from enclosed fire, usually think about carbon monoxide and cyanide poisoning. We will see it later, how to go about the carbon monoxide and cyanide poisoning. Next, yeah. So the other thing to take care of is circulation. As I said, the modality or the approach is the same as any other patient in trauma. But in burn patients, there are some exceptions, especially patients with extensive burns will undergo excessive fluid loss, and this can lead to hypovolemic shock very quickly. And usually assess your circulation as quick as possible, less than 2 minutes. You have to complete the ABCDE assessment and obtain an IV access, check the capillary refill time, check the extremities, temperature of the extremities, the pulse. Is it strong or not? Is it weak or strong? Is it fast or not? So the compromise, if you see any of the three, like the capillary refill is not is delayed, let's say it's more than 2 seconds, then think about that your patient might be going to hypovolemic shock. So obtain IV access to the large bore cannula, maybe 1 or 2, or central line if possible. But central line will come later. In ABCD assessment, maybe you cannot have time to do the central line. You can obtain an IV access quickly. That's why I said you have to ask for help someone else should be helping you when you're doing this assessment. And disability usually assess the level of consciousness of your patient, check blood glucose, and always look for other causes of altered mentation, because your patient may have sustained other injuries other than the burn injuries, because some burn injuries occur in multi-story buildings and people may fall. So think about cervical spine injury, think about head injuries and other life-threatening injuries, not just the burn, depending on the history of what happened or the mechanism of injuries. So think about shock maybe, or other injuries, carbon monoxide poisoning, or cyanide toxicity as well. And you have to fully expose your patient. Why? Because you have to also assess or grade the severity, the total body surface area that is burnt. Now, you cannot do that if you have not exposed your patient fully. But again, you have to expose your patient to assess for other injuries, as just said. And if necessary, decontaminate your patient if the type of burn was chemical burn, especially in factories. And make sure your team is wearing the correct PPE all the time, especially if we are dealing with chemical burns. And avoid hypothermia. Yes, you expose your patient, but after assessment, make sure the patient is covered to avoid hypothermia, and maybe to put the skin moist. So, Dr. Casey, you can go ahead on how to estimate the size of the burn.
All right. Well, thank you for walking us through the initial assessment. Part of this assessment would be estimating the size of our burn. So we're going to go into more detail on how to do this. So burn size estimation. We need to be able to estimate the percent of the total body surface area that is involved in the burn, because that's going to help guide our management. As Dr. Mbugi mentioned earlier, body surface area differs quite a bit in the pediatric population as compared to our adult patients. So here we have a chart that's oftentimes used to separate different sections of the body and about what percentage total body surface area that encompasses. So you can see how it's divided up for children and for adults. But remember, our head is going to encompass quite a bit more, quite a bit higher percentage as compared to an adult. So if you have an infant under the age of 1, it's about 9.5% for one half of the head, as compared to an adult, half of the head is about 3.5%. So remember to be thinking about this in terms of infants, young kids, and then adults. This is just another drawing to kind of help you remember how to use this. If it's a small burn, they oftentimes recommend using the palm of the patient, which is about 1%, to kind of use their palm to estimate the size of a small burn. But this is more helpful when you're doing a full assessment and they might have more extensive burns. So remember, front and back, that each counts. Okay, so at this point in time, I would like to have some participation from our audience where we work on assessing what the total body surface area involved in this burn might be. At this point in time, feel free. We'll give you the opportunity to unmute if anyone is willing to participate. Oops, sorry, I skipped through them on accident. How about this one?
Dr. Cassidy, are they writing on the chat, or they have to say something?
I said they can unmute and say something, but if any of our moderators are watching the chat, if people are putting things into the chat, you can let me know that as well.
Yes, Zahra, you can go ahead saying something.
Any takers? Is there anything in the chat?
Not yet.
Not yet.
Not yet. Okay. Maybe just a few more seconds. I understand there's a lot of people. Maybe Doctor, would you mind trying to kind of estimate here, just while people are being shy?
Maybe Dr. Cassidy, maybe you repeat the question and then everyone can listen
Yeah.
carefully and probably they can respond.
Sure. So we have a patient here, this picture, and we have a pretty large area of burn. I would like everyone to try to estimate about what % of the total body surface area is involved in this burn. Well, just for the sake of time, I'll kind of walk you through how I would do this. So, oh, we have someone who raised their hand. Focus?
Okay, I'll try to estimate.
Okay.
So for a child like this, the back is equivalent to 18%. So when you see this hand, like I think it's like 16% of the back is whole bent. Also, when I go to the buttocks and the back of the thigh, which are equivalent like to 7% each thigh, so you can see like half of it is bent bilateral. So I can take 16 plus 3.5 and 3.5. I get almost maybe 20, 16 plus 7, almost 23% bent.
Yeah.
So maybe
Great job. Thank you.
maybe add the depth of the band. So when you see that depth, that is I think that is for deep, superficial deep. That is deep thickness,
I think
superficial
that's
deep.
deep. Yeah.
Yeah, you
Yeah.
see that it is mixed deep band. So you see that the white area is deep thickness, superficial deep,
Yeah.
and some areas of partial thickness, like here and the buttocks. Thank you.
Yeah. Thank you so much for participating. And I totally agree with how you went and you approached assessing total body surface area involved. So, yep, the buttocks is its own separate area, the portion of the posterior upper thighs, and then it's encompassing the majority of the back. So, thank you for walking us through that and then identifying how you would classify the burns as well. Obviously, this isn't the most high quality picture, but I think you were doing a good job of kind of noticing the areas that were more white and concerning for full thickness. So great job. This is from a case study, and I didn't show you the other side, but unfortunately, this kid had burns to his lower legs and as well as his abdomen. So he ended up having actually greater than 40% in total, but I agree that it's around 20% for what you can actually see here. All right, thank you. Okay, so this takes us to understanding what we need to do for fluid resuscitation. Because as we described earlier, this is going to be one of the biggest things we need to do because they're going to be having lots of excess fluid loss. So these are some of the different formulas for fluid resuscitation that you might have heard of before. Parkland is one that we commonly use. The fluid of choice for resuscitation in burn injuries is lactated ringers. Obviously, when you're giving this much fluids, your patients are going to be at risk for electrolyte imbalances from the losses and then the resuscitation portion. So if you're able to at your facility, it's really important to monitor electrolytes. So let's walk through with a case. Let's say we have a 5-year-old male. He is 20 kilograms and he comes in with mixed partial and full thickness burns after a pot of boiling water fell onto him while he was grabbing at the stove. You estimate that he has scald burns over about 20% total body surface area. How much fluid should be given to this patient and over what period of time? So we'll walk through this as a group. I won't make anyone do math in front of everybody. But here's how we do it. This is using the Parkland formula. So we have 4 mLs per kilogram times the weight in kilogram times percent total body surface area of the burn. So 4 milliliters per kilogram times a 20 kilogram child times 20% is equal to 1600 mLs. We want to give the first half of that total fluid goal over 8 hours and the remaining half over 16 hours once that's finished. So this means that you're going to give 800 mLs within the first 8 hours and the second 800 mLs in the following 16 hours. What this would mean for this patient would be starting initial fluid resuscitation at 100 mLs an hour for 8 hours and then taking that down to 50 mLs per hour for the next 16 hours. So this is how we approach initial fluid resuscitation in our burn patients. As I mentioned, it's important to monitor the response to our fluid resuscitation. So the fluid of choice, as I mentioned, is lactated ringers. It's really important that you're keeping a close eye on your urine output. So you want to monitor this for a couple of reasons. First, you want to make sure that you're keeping up with the fluid losses and that they maintain an appropriate urine output for that purpose. But you also want to make sure that you're not giving them too much. It's not uncommon that we maybe have an incorrect weight for a child or we overestimate the total body percent that's involved in a burn and we end up giving a little bit too much fluid. So we're aiming to get around 1 ml per kg per hour for pediatric patients. In adults, they say 0.5 to 1 ml per hour. It's a little bit higher in children. So you want to make sure you're hitting around that. So you don't want to have the urine output be significantly higher than that because that could be a sign that you're going to potentially fluid overload them. So you want to monitor their mental status, make sure they're doing okay there. You want to continuously monitor airway, breathing, perfusion, make sure perfusion's intact, monitor electrolytes as able, monitor breathing and SATs because you're going to be at risk for developing things like pulmonary edema with fluid resuscitation. So all these things are really key to monitor while you're giving this amount of fluid. All right, I'll hand it back over to you.
Thank you. Thank you, Dr. Cassidy, for taking us through the fluid management in burn. So other considerations for children with inhalation injuries is toxins. So in this setting, if, as I said initially, if the patient is from enclosed fire, so usually think about carbon monoxide and hydrogen cyanide poisoning. So what are the clinical features of carbon monoxide and hydrogen cyanide poisoning? First, how will you know this? My patient is probably having carbon monoxide or hydrogen cyanide poisoning. So usually the patient will have, if it's not having loss of consciousness or seizure, the patient will have dull headache, dizziness, weakness, nausea and vomiting, can have chest pain occasionally or confusion. And if you suspect that or you have high suspicion index with carbon monoxide, so give 100% oxygen to decrease the half-life of carbon monoxide. The half-life of carbon monoxide is around 300 minutes, which is equivalent to how many hours? Almost 5 hours. So giving 100% oxygen can reduce the half-life to around 30 to 60 minutes to 90 minutes, 30 to 90 minutes, by just 100% oxygen. So measure the CO levels by ordering carboxyhemoglobin level from a VBG. And usually do not rely on pulse oximeter, because carbon monoxide, when it mixes with hemoglobin, it forming carboxyhemoglobin, its wavelength is almost the same as the ox hemoglobin. So the pulse oximeter will always read normal SpO2. So do not rely on pulse oximeter to say my patient is not having carbon monoxide. So the patient can have carbon monoxide poisoning and still have a normal saturation. And carbon monoxide has higher affinity for hemoglobin than oxygen does. Its affinity is almost more than 100 times more than that of oxygen. So giving 100% oxygen, you increase the competition and decreasing the carboxyhemoglobin half-life. So this is I can say oxygen is an antidote for carbon monoxide poisoning, and it's life-saving. And hydrogen cyanide as well. So have a high level of suspicion with cyanide levels, with cyanide toxicity. Unfortunately, you cannot measure cyanide levels immediately, like to have it on hand maybe within a few minutes, and that cannot be clinically useful. And suspect toxicity with the hydrogen cyanide if patients are having also sedimentation and having metabolic acidosis with high lactate levels. So as in carbon monoxide, also administer oxygen, 100% oxygen. And if you have hydroxycobalamin, you can administer hydroxycobalamin. This is an antidote for hydrogen cyanide poisoning, or sodium thiosulfate if you have it. Casey, am I taking this or?
Yeah, this was your section as well.
Thank you. So what are the initial wound management? So usually consider to have initial wound management after you have stabilized your patient. So do not rush to start managing the wound before you have not stabilized your patient. So cardiorespiratory stabilization comes first, and then initial wound management. And what's the goal of wound management? The goal here is to prevent infection and to promote rapid healing. So wound care can, the approach can differ from institution to institution. So usually you can use your local guideline to manage your wound, but universally, this is maybe how it's supposed to be done. So wound care, as a first aid, you can just irrigate with water. This actually keeps the skin moist and prevent further damage. And then remove all burned clothing if they are easily removable. And usually immerse the site in cold water for around 30 minutes. But do not over irrigate. Maybe do not increase the duration to above 30 minutes because of the risk of hypothermia. Irrigation actually on the burn site reduces pain and edema and extensive tissue damage. Watch out the hypothermia in this patient through this irrigation. And apply wraps around the burn area. So usually the non-adherent wraps is advised, like the paraffin gauze. This will also prevent heat loss and hypothermia as well. Next slide. So wound care procedure, all this procedure usually is can be done under sedation, but it depends on the extent of injury, severity of the injury, and the level of pain. So, but to be comfortable with your procedure, you can do it under procedural sedation. So you cleanse the area with large volumes of sterile saline, just like we have seen in the last slide, and loose tissue can often be wiped away with the sterile gauze, and the bulla should be debrided and exercise any areas of necrotic tissues. Large blisters also that maybe overlying the major joints, they are limiting movement or bringing uncomfortability to the patient, or the obscure the assessment of the pan depth can also be removed. But do not remove small blisters, because these act as natural dressing, and they prevent actually bacterial invasion. Do not use alcohol-based solutions. Clean the area after debridement with 0.25% chlorhexidine or other mild water-based antiseptic, like povidone. Antimicrobial ointment like sulfadiazine should be placed on the exposed wound surface, but do not use sulfadiazine in sulfur allergic patients. And following the selected antimicrobial, you have already dressed your patient, and you have already washed the burn wound, and you have applied your topical antimicrobial. You place a layer of petroleum gauze, the non-adherent one, followed by a dry gauze wrapping. I think everyone does that when he gets a burn patient. And when do we change the dressing? Again, this should be very individualized when to change the dressing. So it depends on the extent of the wound. Is there an infection? Is there no infection? How big is the wound? So this will have to be individualized, but usually depends, as I said, on type of burn, but usually once or twice a day can be done, and may require further debridement of necrotic tissues if they are forming. But some clinicians can opt, like the wound is clean, no signs of infection, can go up to 3 to 5 days for the next change. And prophylactic antibiotics are not recommended in this setting to prevent antibiotic resistance, unnecessary antibiotic resistance. You have to be doing maybe blood culture in the ward. And how do we manage pain? Usually pain management in any procedure is quite necessary, because we advocate for pain-free procedures in children, not only in children, even in adults, we have to be doing the pain-free procedures. So it's necessary to take care of the pain. We can start with non-pharmacological measures like calming the patient, and you have to keep maybe a caregiver, a caretaker around, or the child should be comfortable with the environment. You have, if the mother or any other caretaker should be just around. And calm the patient, developmentally appropriate verbal reassurance. For like a 4-year-old, you have to reassure, like, it's fine, it's gonna be okay. The reassurance also helps to calming down the children. Even to preverbal children can reduce anxiety and dramatically reduce the perception of pain. So you can opt to have a kind of multimodal pain management, or just use opioids as well, because some children may not respond to non-opioids analgesics. So you can use opioids like morphine or fentanyl. But in this setting, it's good to use fentanyl because it has less cardiovascular effect than that of morphine. Morphine has Morphine has a long half-life, but it has cardiovascular effect. And when you're using opioids, usually try to maybe to maintain your circulation by giving IV fluids. Make sure your patient is getting IV fluids, because opioids can take down the blood pressure and deplete the volume. Other modalities, the intranasal analgesics, like fentanyl can be given intranasally, and ketamine as well can be given intranasally. It can help alleviate the pain even before you have inserted the IV, because you're just giving it intranasally. The other thing to note in pain management is IM injections and oral doses. Usually, we do not give IM injections and oral doses in burns, especially severe burns, because the absorption in the muscles is quite reduced in severe burns, and even in the GI, the absorption is very low. You're taking this, Cassidy, right?
This is me, yeah. So a couple other quick additional considerations is just like assessing, is the burn clean appearing? Is it contaminated appearing? And this should raise your concern immediately for, does this patient need tetanus prophylaxis? And in most cases, the answer is going to be yes. This is just kind of a way to assess wounds, clean minor wounds. Have they had their routine recommended immunizations against tetanus? No, give the vaccine now. If yes, make sure it was within the last 10 years. Don't waste time on this portion. Like if you can't get a straight answer and you can't review someone's immunization status quickly, administer the vaccines to prevent any issues, especially in a burn wound. Another key consideration in pediatric burns is nutrition. Patients recovering from acute burn injuries will have significantly increased caloric needs. We think about the resting energy expenditure of children. It's already a little bit higher than adults, and then having a burn injury keeps it high for quite a bit of time during the healing process. There's also a chance that maybe some of our children suffering from malnutrition even prior to the burn injury might come in with that. So keep that in mind. If necessary, consider early placement of an NG tube to make sure that they're going to be able to take what they need to ensure that they have the adequate calories they need in order to go through this healing process. You won't heal properly from these burn injuries if there's things like anemia or malnutrition, so it's really important to just avoid that in the first place. And we've talked about this, our biggest point today is, doing your initial assessment and stabilization, but thinking about, when does my patient need to go to a place that has a burn center? This would be suggested that any patient in pediatrics who has partial thickness burn or worse, that encompasses greater than 10% of the total body surface area, they should get transferred to a burn center. Or if there's like an area that's maybe smaller than 10%, but it's full thickness throughout, that should be referred. Think about the nature of the burn. If there's a high voltage electrical injury, a really bad chemical burn, circumferential burns, or any kind of signs of inhalation injury, those patients should be referred as well. Think about areas that are going to be at high risk for complications. So these include hands, feet, genitalia, perineum, major joints. They'll probably do better at a burn center as well. Lastly, thinking about comorbidities, the presence of things that could complicate management. In our setting, think about severe acute malnutrition children, think about patients with diabetes, other things like that that could prolong recovery. Never be afraid to refer them to an area that has more burn center resources. This takes us into talking about another topic that's important in pediatrics to think about, which is non-accidental burn injuries. Non-accidental trauma for children presenting with a burn injury has an incidence rate of 9.7%. So of kids presenting with burn injury, this is really from the United States, up to almost 10% of kids, those will be non-accidental burn injuries. And up to 20% of all pediatric burns are related to abuse. If there is suspected child abuse going on, the likelihood of death due to a burn injury can be up to 4 times higher than other burn injuries. Scald burns are not only the most common type of burn in general, but they're also the most common type of non-accidental burns in children. So here's a picture of an inflicted scald burn in which a child was forcibly submerged in hot water and they suffered burns. So this would be called like a stocking distribution. So sometimes we think of stocking glove distribution. So the same thing would be present on the hands and wrists. Those are concerning findings. This is another picture of a kid who was also forcibly submerged into hot water. So what you'll notice here is that he has areas of pretty significant burns to the legs and the sides of the buttocks and the lower back, but he has this small area of the buttocks that is spared. As Dr. Mbugi mentioned in the beginning, scald burn injuries depend on duration of contact with the hot liquid. So essentially when a child is forcibly sat into a bath, that part of his buttocks is touching the bottom of the bath, but the surrounding hot water is touching the other areas, and that's why it spares that small portion. So this is another finding that you could see with a burn injury that'd be concerning for a non-accidental burn injury or an inflicted burn injury. So this is a quick table just to go over like things that should be concerning and raise red flags in the history you gather and things on physical examination that should worry you. So just always think really cautiously about any kid presenting who's less than 4 years of age. Obviously, that's still going to encompass the majority of our pediatric burn patients. Think about, is there a good explanation for my injury here? Is there an inconsistent explanation from different caregivers? Does the mechanism that's being provided to me make sense with what I'm seeing on exam? Is there a very significant delay in presentation? Or does this kid also have like chronic medical conditions, developmental delay, behavioral issues that would put them at higher risk for abuse? On your physical exam, look for things like pattern injuries. So you can see circular burns when patients have cigarette burns where a cigarette was put out on their skin. Iron burns can have a pretty distinct pattern. I showed you a picture of the stocking distribution and we discussed what the glove distribution would look like. Think about how a patient might get a very sharply demarcated border type of burn and make sure it makes sense with your story. I showed you the picture of the sparing of the buttocks are flexion creases for kids who were forcibly submerged. Whenever there's bilateral lower extremity involvement, do consider if you need to raise suspicion for this. Think about this with really severe burn injuries. Also considering it was this injury the result of neglect. All right, I'm going to quickly go through complications of burns. I know we're kind of running out of time here, but just want to mention these things quickly. Infection and sepsis, this is what the majority of our burn patients are going to really struggle with. It's the leading cause of morbidity and mortality in pediatric burn patients. The risk of infection is directly correlated with the TBSA of the burn in the presence of an inhalation injury. The reason that infection
Looks like we lost her connection.
Yeah. Let me check with Cassidy. See.
So it looks like Dr. Cassidy has lost her connection for a moment. We will see if she can rejoin for the last few minutes of the presentation. For those in the audience, it looks like she's rejoining now. But if you have any questions for our presenters, please go ahead and put them in the chat. And if you have not yet done so, please put your MCT number and your name in the chat so that you can get CPD points.
I'm so
Hello.
sorry about that. My
Okay,
internet cut out.
feedback. All right.
I apologize, everybody.
No worries. It happens.
Let me try to get back to my. All right, are you able to see this?
Yes.
Okay, I'll go quickly through this. I apologize. We were discussing the risk for infection and sepsis, and in burn injury, there's persistent inflammation, immunosuppression. So you have an increased risk for quite a prolonged period of time of developing sepsis. Common bacteria are Staphylococcus aureus, Pseudomonas, amongst others. So topical antimicrobials are used, as were mentioned in the basic wound management, but we discussed that systemic antibiotics should not be given prophylactically, only when indicated. Everyone who has a severe burn injury is at risk for respiratory failure, hepatic failure, acute kidney injury, and renal failure. If you have 3 or more organ failures, you're at high risk for mortality with a burn injury. Acute compartment syndrome is something we really need to worry about in patients with extensive burns, especially if they have a circumferential burn. Circumferential burns means that the burn encompasses all the way around. So this could occur on an extremity where the burn wraps all the way around, like the lower leg or the arm. It can also occur on the chest and abdomen, and it can restrict how someone's able to breathe. It can make you at risk for abdominal compartment syndrome. So think about this when there's like extensive pain that's out of proportion to the injury, pain with passive stretch in the extremities. If there's any kind of neurovascular compromise, no more having palpable pulses, this would be very concerning and would mean that you should perform an escharotomy, which is where you cut through the area where there's a full thickness burn down to the layer of the fat, and that will release some of that pressure to avoid further issues from compartment syndrome. Occasionally, people who have really extensive burns might require fasciotomy, but it's not recommended that you initially proceed with fasciotomy. After burns are in the healing process, there's a risk for contractures, so it's really important to take good care of the burns and put patients in splints and orthotics as they go through the skin grafting process to prevent contractures, especially at joint areas. We want to take this very seriously in the neck area, in the hands and feet, large joints, things like that. So that's where being at a burn center can be really helpful. All right, long-term complications, they have a higher age-adjusted mortality. They're at risk for chronic conditions, at increased risk for respiratory conditions later on. All of this stuff is pretty persistent for all of our burn patients years after they initially recover. We don't really have time for these cases, but, and I'm sorry I had to speed through the complications portion, but we wanted to just open it up now to see if anyone had any questions.
Yes, thank you very much, Dr. Mbugi and Dr. Cassidy, for a very wonderful presentation. So I picked up 2 questions from the chat as of now. So the first question is from Zaitun. He was asking, can you kindly repeat on the assessment of burn percent? That is the first question. Then the other question is, in case you receive a burn patient on which the first 8 hours since burn event has already passed, how could you approach such patient? And I think most likely the participant is referring to fluid management, where you spoke about the initial 8 hours and then the other 16 hours. So those are the two that I've seen on the chart, unless I missed any.
Great. Well, Dr. Mbugi, maybe I'll let you take the first question since that was from your section.
Okay. What the fluid light about the
I think the initial question was just like, can you quickly repeat the assessment of a pediatric burn patient?
Okay, can we go back to the slide with the
I'll try, but I don't know if I'll be able to, but I'll try.
Well, we need to show the slides that talks about the was it the initial assessment or the burn percentage assessment?
Burn percentage.
It's the burn percentage assessment. So, Dr. Zaitoon, I think the sketches here explains themselves. So if the burn area is small, so usually assess many times your hand covers the area. How many times your hand covers the area? So like front is 4.5. Maybe this is for adults. Maybe let's check on the right side of the slide. The front is A and back is D. So depending on the age, maybe let's say at 10 years. At 10 years, A, if the baby is having burn injury on the front of the face and head, that means just on the front it will be 6%, right? Because A 10 years is 6%. If it's back and forth, then 6 times 2, it becomes 12. Likewise on other areas. So you can use this diagram and the description below it to calculate the total surface area burn. Dr. Zaitoon, have you understood this sketch here? You can unmute yourself and say yes if you have. Okay, thank you. She has said maybe she has understood about this diagram.
Great. Yeah, and these are easy to just find on Google so that you can have them for your reference. And I've noticed them in a lot of emergency departments pasted on the walls with burn protocols so that you can reference this to know, okay, I'm looking at the chest and abdomen. Okay, that's about 13% for this infant. So you can assess it that way. And then the second question was about fluid administration if they came to you after 8 hours. So this is just when you get the initial burn patient. They're going to be at really high risk for fluid losses. They're not ever going to arrive to you immediately after having a burn injury. So you're going to see them some point in time. This is just from the time of initially starting fluid administration. You count that 8 hours and you give half of the total fluid, followed by the remaining half over 16 hours. Great question.
So the other thing is when you are managing with fluid in these kind of patients, usually you can under-resuscitate or over-resuscitate. So careful monitoring of your resuscitation is quite necessary. always monitor what you are giving. By monitoring, Dr. Cassidy said, the urine output and vital signs as well, probably with mental status. So if you're giving fluids by using calculations, usually you cannot have exact percentage of burn. That's not possible. So it's just an estimation. You can either underestimate or overestimate, meaning what? You can over-resuscitate or under-resuscitate. So always monitoring or reassessment of your patient is quite necessary, not to over-resuscitate or to under-resuscitate, because you can cause harm or not.
Okay, thank you very much, presenters, and also the participants that have really engaged in our today's Pediatric Emergency Medicine lecture series. And again, as we said, we are very happy as we have begun the year with a very good, interesting topic, because this is our first PEM lecture series for the year 2026. And just to inform our participants, we always have this every month, and we always share the posts within our social media just to let you know when we're having the next one and what's going to be the talk for that next month. So always keep an eye on different WhatsApp groups, different social medias that we also put this information for you so that you can also prepare and come in with different questions that you have for that particular talk. So before we wind up, just a quick reminder for all the participants that have joined in. Make sure that you have written your name and the MCT number for your CPD points. And just make sure you do not have any debt with MCT, as the CPD points will not be claimed for you. And the other quick reminder is we always like to prepare our talks based on what the participants faces or always meet within their health facility. So in the group, I've just shared a link for your feedback. And within that link, you'll also have an opportunity to write in what topic or what talk you wish us to prepare for you that is going to be helpful as you keep on practicing at different health facilities. But as well, all these lecture series are recorded and you can always watch them on our YouTube channel. If you missed the last year's lecture series, because we presented 12 lecture series last year, you can just go on the YouTube channel and you can watch the recorded session. Likewise, the ones that we have begun this year, they will also be recorded and they will be placed in the YouTube channel for anyone at any time can keep on learning and reminding. So I've also shared the link for the YouTube channel. Otherwise, I'd like to say thank you to all that have joined. Thank you to our presenters and the moderators. And I would like to wish you all a good evening and a good morning to our colleagues in the US.
Thank you, Dr. Humphrey. There is a question.
Thank you.
The question, I think we can take that for maybe for the future lectures.